easy it was to put a TAVI valve in, but it's I can assure you, very difficult to take one out when it's necessary. So how do we surgically treat, we deal surgically with failed TAVI valve? And why does this operation matter now? That's because, in the US, lately, 80% of the aortic valve replacements are done percutaneously. And I'm sure this will follow in Europe and in Greece shortly. So we have recently 6,000% growth in TAVI explant in the reported series between 2012 and 2023. And you saw that around 2015 to 2016 in the US, the TAVI valves surpassed the surgically inserted aortic valves. So we can understand how important that is when the incidence is 0.2 to 2.8% reported incidence of explant after index TAVI across all studies, with more than 10% 30-day mortality in most published series. So why this operation matters now? Because the reintervention horizon is rapidly shifting. TAVI is expanding fast into younger and low-risk populations. We'll see the guidelines going lower and lower ages. So we have multiple failure modes that were rare in the past. Now, because the denominator is increasing, have become more central in a patient's lifetime to valve strategy. So a successful TAVI program must be able to answer the explant question. So can this patient safely undergo the next procedure, which can be TAVR in TAVR or SAVR after TAVI? And you can see the projected incidence until the next 10 years, till 2035. TAVR in SAVR is going to be, of course, rapidly increasing. TAVR in TAVR also, but also surgically aortic valve after TAVR will also increase, just because, again, the denominator is going to be so great. So the language does matter. We have the failed TAVI valve, redo TAVI, and TAVI explant after surgical and surgically inserted aortic valve. The failure modes are divided in three categories: acute and procedural. That's when the valve embolizes or is malpositioned. When there's acute severe IAI without any bailout techniques available. When the coronary ostia have been obstructed without the chance of PCI. And of course, when you have complications such as dissection, rupture of the annulus, and migration of the valve. Subacute failure mode is days to weeks, when the valve thrombosis, when we have early structural failure, when there's early endocarditis, again, paravalvular leak, not amenable to percutaneous repair, and we have severe conduction system injury. And late, that's what we see mostly is structural valve deterioration, some late endocarditis, calcified duodenal with destruction of the valve, when there's a fracture of the frame and deformation of the valve, and also progressive PPM. The timing is also very important. Emergency procedural cases have a very high mortality, between 30 and 50%, when the valve embolizes with hemodynamic collapse, when we have acute AI 4+, when again is coronary obstruction not amenable to PCI, and when the annulus ruptures with tamponade. These are very hard cases with very, very high mortality, because usually they happen in a chaotic situation and environment in the cath lab. Urgently, these cases are done usually within 7 days, when it's early endocarditis or uncontrolled sepsis, where we have recurrent embolic events from the valve, and when the valve has failed with progressive heart failure. The mortality again is pretty high, up to 25%. And most cases are elective, more than 7 days, when there's a subacute or chronic valve deterioration, endocarditis, despite antibiotic course or destruction of the valve, when there's recurrent PVL, and progressive PPM with stable hemodynamics. Again, number one cause is infective endocarditis, when we have a large vegetation with an abscess, with persistent bacteremia despite antibiotic therapy, embolic events, and the prosthesis is destroyed by the bacteria. PVL with hemolysis is also very important when it's refractory and there's no percutaneous bailout, and also malposition of the valve, structural valve deterioration with stenosis or regurgitation, and especially when redo TAVI in TAVI is unsafe and unfavorable anatomy. When there's PPM, again, one valve in valve will make things worse, or also when there's concomitant pathology that needs to be surgically addressed, such as CABG, mitral and tricuspid surgery necessary. Before the surgery, we need a careful workup with echo, ideally transthoracic and transesophageal, to see the exact pathology. We need CT of the chest, abdomen, pelvis in order to identify the valve frame, the situation of the condition of the aorta, and possible cross-clamp cannulation sites. We need, of course, coronary cath to see the how high the ostia are, if there's any coronary disease, and the exact anatomy of the coronaries. And if they're in cases of endocarditis, we need careful infection staging with cultures, exact organism, antibiotics, and antibiotic strategy, of course. The valve design is of the utmost importance. If it is a balloon expandable valve, usually these are like the Sapien, a shorter frame. Usually they sit intraannularly inside the annulus. And here, standard ascending aortic cannulation is feasible, and the aortotomy is done 1 to 2 centimeters above the STJ. And usually the roll technique is the most favorable to take the valve out, even though I can assure you, I've seen a couple of these cases are very, very difficult to remove these valves. The self-expanding valves have a taller nitinol frame, which means you have to either cannulate the arch or in the periphery, femoral or axillary or even carotid, and the aortotomy needs to be done a little higher. The complexity, again, is dictated by the valve, time since the TAVI procedure. Some late cases have developed neo-intima and adhesion, so the access to the aorta can be very cumbersome. We need to know the implant depth, again, the coronary geometry, and if there's any concomitant diseases. Exposure is very important. The cannulation site, as such, cardioplegia strategy is, again, very important. How we're going to vent the heart and exactly where to do the aortotomy. We need to have carefully planned our procedure before that. And whatever works to take safely the valve out without destroying the root can be done, either using double cork technique, rolling technique, tourniquet, or the handlebar technique. Again, whatever works. No one really in the world has done like hundreds of these cases. That's why all the surgeons' experience is limited to just a few cases. No, now the explant is one, but you have to see if there's anything else that needs to be done. If you're lucky enough, you just have an isolated aortic valve replacement. If the root and the aorta are intact and the annulus is welcoming a surgically inserted valve. Sometimes in PPM or small annulus, where the gradients are going to be postoperatively high, we need to do annular enlargement. And now things can get complicated. If the root is destroyed, or if there's an abscess, then we need to replace the root. Sometimes we need to repair the ascending aorta with a patch. We need to see if there's any damage in the coronaries, and also if there's any other valves that need to be surgically addressed in order to guarantee a safe and successful outcome. Endocarditis is the vast majority of these cases. Usually it's persistent bacteremia or uncontrolled infection with a large vegetation, can have an abscess, and the valve is usually destroyed by the bacteria. So we need to carefully manage and plan these cases with transesophageal echo, CTs, cultures, ID consult, and CT of the brain, the spleen, the kidneys, in order to see if we have any embolism. And also we have the registries in Europe, the explant TAVR registry that follows these patients. Complications can be, as you can see, a bunch of them. You can have aortic or root injury, have coronary injury, have stroke, embolization from debris or material from explanting the valve, of course, bleeding, coagulopathy, conduction injury, LVOT injury, mitral injury, and residual PPM, because again, the surgically inserted valve that we can put may not be accommodating the size and the hemodynamics of the patient. So as we move forward, we have, and I'm sure we'll keep seeing, new generations of TAVI valves that are a little more friendly, if we can say that, in explantation, with weakened strut zones that you can transect, maybe with bioabsorbable frame elements. So the industry collaborating with surgeons to see if we can develop such valves. There's definitely surveillance protocols. Training is a different story because, as I said, there's not many surgeons have done, fortunately, a lot of these cases. But as the TAVI numbers keep growing, I'm sure we'll keep seeing more and more of these patients. That's why we have the Resolve registry in the States and the Explant TAVI in Europe. So concluding, TAVI explant is a lifetime management problem, especially patients, younger patients, healthier patients that receive TAVI. Explant, when redo TAVI cannot be safely done. CT and TE must define the anatomy and carefully plan our surgically approach. The valve architecture matters between balloon valve and self-expanding valves. And the outcomes are improving, but again, these are cases that are very hard to do with, and I'm sure all the surgeons agree, with very, very high mortality. I tried to rush a little bit, so we gain some time. Thank you so much.
Well, great presentation. Thank you very much. I mean, it's a really big issue for us. We really think twice when we have to ask the surgeon to explant the TAVR. And if it's like a self-expandable device which goes in the aorta, you have to do the ascending aorta also. So it's very difficult installation. I would like to ask you, we have discussions like lifetime management and treating younger patients. Does that not exclude automatically like the option beginning with TAVR in a patient due to the fact that you just definitely have to do an explantation? And this is the first question. And the second question would be, would you think about an option that maybe we should consider facilitating with reinserting the coronary ostia, doing more than aortic valve replacement in a younger patient in order to facilitate lifetime management over 25, 30 years and consider like valve-in-valve implantation after surgery, which will be a much more complicated operation, definitely involving the coronary ostia?
Well, as Dr. Spilla said, to do TAVI, it's going to be very complicated, causing PPM. So when you have a young patient and the guidelines keep reducing the age, is now 50, 70, used to be 75, then you may end up in a lifelong patient, 3 valves inserted. Regarding the ostia, it's much more complicated because you cannot really stretch the coronary ostium to a higher position. You have to do a cabrol, which complicates the procedure by a lot, increasing the morbidity and the mortality.
And annulus enlargement, what would you say about regarding
yes, annulus enlargement is routinely done because a 19 valve, as we have discussed it many times, the heart team is pretty much not acceptable anymore.
And Dimitri, may I ask you, so we see also the new data coming from the States. They have a lot, smaller mortality as compared to the initial phases of TAVI explantation. So maybe surgeons started to know how to deal with the procedure. For instance, maybe they are doing that. Maybe there are some differences in how to explant the self-expanding valve as opposed to a balloon expandable valve, right? So maybe people are starting to have a proper learning curve, and
that's true.
Maybe we should focus in promoting. Maybe it's not for everyone. I mean,
or maybe surgeons refuse to operate.
Why?
Why? Because mortality is 30 to 50%.
But it was, I think it was in the past, so the new
the
data
past.
coming from the TVT registry,
I think
they're in a lower single digits, because now if you want to explant the TAV in an evolutive platform, it's not like you're taking out, maybe.
No, that's true. And I think
Maybe
all these cases.
you need to have some eyes the way that you place initially to prepare the valve, maybe by using refreeze the valve. Maybe you get you make it more accommodating. This is the technique that people are telling. Maybe it's a solution.
No, that's true. And as you said, maybe this case should be done in tertiary centers, like Onasio, like Avgerinos, most that have the most experience, because it's not cases for everyone.
I think that Yannis, the right person was Dimitris to talk about that, because he is an aortic surgeon, and I think that for the late, mostly for the late explantation, you don't need a roll or a double cochlear technique. You need an aortic surgeon that can resolve problems with aortic root, and Gabrol. You cannot do Mendel or things like that. You must make Gabrol or other techniques, and this is with very high mortality, and not because the microbiology of the valve is different, but because after sometimes the frame is compact with the intima, and you must make.
And Dr. Chalapas, and also we have from connected Dr. Pattakos, who is the next speaker.
Great presentation, very comprehensive. I think in some cases, SVD cases, hybrid solutions like surplus procedure will be a very good option. And do we know in Greece how many TAVR explantations have been done up to now?
I have no idea. Maybe Dr. Stavridis knows his numbers for Onasio.
We've done 2 so far, so we have an excellent.
It's a good.
Acute or late or an emergency?
Well,
I think they were
not.
Yeah.
Not acute, yes. So the denominator is sufficient. It's 2, it's fine, I think. So thank you, Dimitri.